An additional few days of abstinence might not seem like much, but each day of sobriety allows the brain to heal, and it also gives the person time to work on developing new coping mechanisms and get social support during this critical time.
Often in the AA community, it is one day at a time. Take each day towards recovery and take it slow and take it one day at a time. And that's essentially what we were seeing, that each day of abstinence mattered.
That's Dr. Sara Blaine and Dr. Rajita Sinha, who will talk about their article on the use of brain imaging in the evaluation of drinking outcomes during early outpatient treatment for alcohol use disorder. Their work appears in the November 2020 issue of the American Journal of Psychiatry. I'm Michael Roy, Executive Editor of the American Journal of Psychiatry, and this is AJP Audio. Dr. Sara Blaine is an assistant professor in the Department of Psychological Sciences at Auburn University. She recently completed postdoctoral work at Yale University. Her work has looked at how genes and aspects of the brain affect the development of alcoholism under conditions of stress. Dr. Rajita Sinha is the Foundations Fund Professor of Psychiatry at the Yale University School of Medicine, where she also is a professor of neurobiology. She is chief of the psychology section in psychiatry and co-director of education at the Yale Center for Clinical Investigation. In addition, she is a professor in the Child Study Center and founding director of the Yale Stress Center. Her research has looked at the mechanisms of chronic stress, adversity, and coping. She's also interested in developing new ways to counter the effects of stress and addictive behaviors. Dr. Blaine and Dr. Sinha are co-authors of an article in our November issue entitled Association of Prefrontal Striatal Functional Pathology with Alcohol Abstinence Days at Treatment Initiation and Heavy Drinking After Treatment Initiation. Dr. Blaine, Dr. Sinha, hello and welcome to the podcast.
Hi, thank you for having us.
Hello, nice to be here.
Now, you have both done work on how changes in the brain and in the environment affect a person's behavior and response to challenging or stressful conditions. Before we get into the details of your article in the journal, could you both tell us how you became interested in this area of research?
Well, individuals are faced with stress every day, and we do all kinds of things to cope with stress. One of the very common things we do, and you hear this all the time, is that we drink. There are all kinds of beliefs about drinking. There's a belief that drinking helps us relax or cope with the stress and anxiety of life. However, how we all manage the drinking, the number of drinks we have under stressful situations or non-stressful situations, and how stress is managed is determined by whether you have an illness or not, or whether you are sick, or whether you're coping with certain chronic illnesses. And both stress and drinking can alter our brain circuits that are involved in regulating stress, regulating our emotions, and regulating reward or regulating the feelings of pleasure when we engage in anything that's pleasurable.
Yes, I also got into this work because on the one hand, as Dr. Sinha said, alcohol is ubiquitous and accepted in our society, but on the other, it's associated with so much loss and despair. So I've always wanted to understand the neurobiological and psychological mechanisms that underlie someone choosing alcohol above their family, their relationships, their work, etc.
So your article in the journal examined the use of brain imaging in the evaluation of drinking outcomes during early outpatient treatment for alcohol use disorder, or AUD. Why did you and your team want to study the neurobiology of individuals who are in the early phase of abstinence from alcohol?
So one of the things that we know is that it's very hard to stop drinking. And when we do stop drinking, particularly for those who have a problem with alcohol use disorder, it is very hard to maintain that abstinence and to reduce drinking in early treatment. People are motivated to get treatment and initiate recovery, but there are lots of problems related to that. One of the big ones is that, in fact, our brains are affected in a very potent way by the high levels of alcohol intake, our brains and our bodies, actually. And what we wanted to do here was to really understand, why is it that people drop out or are unsuccessful in the early phase of treatment? Those are at very high rates. People say initiating recovery is difficult, and there's high relapse in the early phase of treatment. So we wanted to study that in more detail.
Right. And previously, we have seen some work by other people in the field on people who've been able to maintain abstinence for a longer period of time, months or years, but that is not people's usual experience. And so we wanted to look at those very first few weeks.
Now, your article discusses several regions of the brain that have been shown to be affected by chronic alcohol intake. You note that changes in these areas have been linked to stress and reward circuits that may have a role in craving and risk for relapse. Could you talk about these brain regions and what we know about how they may be affected in addiction?
Yes, sure. So we targeted a critical region, which is the prefrontal cortex. And the prefrontal region, our work and the work of others has shown, is very susceptible to the chronic effects of alcohol, as well as the chronic effects of stress and adversity. What we have shown is that not only is it affected by the chronic alcohol intake, but also it tends to impact our ability to cope with stress or with alcohol-related situations, and is involved in predicting future relapse. So we targeted this region and its circuits. So this region also has connections with the reward and emotional circuits, what we have listed in this paper as the striatum. The prefrontal circuit is the medial prefrontal circuit, and we hypothesized that this striatal frontal region and network or pathway is very involved not only in taking the hit from chronic alcohol use, but also in helping us regulate ourselves under conditions of stress and challenged by alcohol-related stimuli in the environment, which are often the triggers for relapse and for return to drinking. And so these were the triggers that we wanted to see how the brain responds to under a controlled experimental situation.
So as described in your article, you actually conducted two related studies that used a unique functional MRI approach. The first study involved showing patients a set of visual cues for alcohol, stress, or neutral stimuli. And the second study measured drinking outcomes during early outpatient treatment. Could you provide more details about this design and about the patient population?
Let me start, and then I will ask Dr. Blaine to elaborate. I wanted to just clarify that in study one, a critical point is that our patients were, in fact, also compared to a healthy drinking group. And the reason for that was to assess, as people are coming into treatment in that early phase, how do their brains look compared to those who are not struggling with alcohol use disorder. And a critical variable there that we wanted to explore was how many days had they been abstinent, those who have a problem with alcohol use disorder. Because as I said earlier, the number of days of abstinence is hard to accrue in the early phase of treatment. And we hypothesized that this might actually have a really important clue, give us a clue about how the brain is starting to recover from alcohol use disorder.
Right. And just regarding the participants with alcohol use disorder in the study were adults in their 30s with some college education who have been drinking for 13, 14 years on average. So they're currently drinking about 2 out of every 3 days and are having around 6 drinks per day, with some people having more, some people having less. At the time of the brain scanning, most of them had between 1 and 5 days of abstinence, but some had up to 30. As far as the study design, after they gave informed consent and underwent baseline psychological assessments, all the participants underwent the MRI scan, where they were exposed to 3 sets of images: appetitive images of alcohol, stressful images of aversive or threatening situations, and neutral images in a randomized order. And then after we measured their brain response to each of these, participants were contacted daily to report if they had consumed alcohol and how much they had consumed if they did. This is done via computer and smartphone apps, so there was no interpersonal pressure to lie or feel ashamed of anything that occurred.
And I'd like to add that the first study was much more, was basically focused on comparison of the healthy sample to the patients. And the second study involved what Dr. Blaine clarified, which is the assessment of their drinking for the patient group over the 2-week period as they engaged in treatment. So they then, after the brain scan, initiated treatment. They got counseling, and this is outpatient treatment. They got weekly counseling and were able to come to the center for those sessions.
Well, I'd like to discuss a little bit more about those additional methods that you used during this study, in addition to the MRI paradigm. As you say, the study involved counseling, physiological measurements, and daily diary entries. Could you talk about why you opted to use these different measurements and how you went about analyzing the data?
Let me talk a little bit about the assessments, and Dr. Blaine can speak about the data analysis as well. We wanted to essentially present what happens to patients as they initiate recovery when they're entering an outpatient treatment setting. So the measurements were, we want to assess drinking, of course, as well as how their body is starting to recover or functions in the early phase of treatment. So their physiology, heart rate, blood pressure measurements were taken, as well as how motivated they are, how they are coping with life on a weekly basis, how their mood is, and how their anxiety levels are in that early phase. And then they would have a once-a-week counseling session, which is about 45 minutes long. And we would ask them how that went, as well as how much drinking and what are sort of the trigger points that put them at risk for jeopardizing this motivation for recovery. And the second study essentially just focused on the first 2 weeks because we were looking at that early period.
Yes, so as Dr. Sinha said, just to validate that our paradigm was working, we did collect heart rate data and cortisol response to the alcohol, stressful, and neutral images. We saw changes in heart rate and cortisol levels in response to alcohol and stress cues, which indicated that the visual cues successfully elicited craving and stress responses. To analyze these changes, Dr. Fogelman, who's an author on the paper, looked at the difference between the heart rate and cortisol in response to the neutral cues versus the alcohol or stress cues, after first correcting for each person's baseline heart rate and baseline cortisol levels. So these were important validations of the new paradigm that Dr. Seo and Sinha developed. Dr. Sinha discussed the 12-step facilitation therapy that they did, which was developed by NIAAA. And then, as we said, the prospective daily diary assessments were completed for 2 weeks after the scans to allow for more accurate data collection than retrospective self-report by participants, which has been used in the past. And Dr. Wem, who's also an author on the study, used this data to calculate an aggregate measure of how long each participant successfully remained abstinent and the number of heavy drinking days each person engaged in during that 2-week window.
And we can add about the brain imaging analysis as well. We have 2 authors on the paper who were involved in the brain imaging analysis. And the way this is done is that participants are responding to these alcohol or stress or neutral images, as Dr. Blaine mentioned, and the brain is recording a measure of blood flow, or what we call functional magnetic resonance imaging response. a critical thing here is that we did whole brain analysis, even though our hypothesis was very focused on this prefrontal striatal circuit, which is a circuit that's involved in emotion and reward regulation and has been shown to be involved in craving and desire, as well as in relapse risk. That was our hypothesized target region. We wanted to let the data tell us that, in fact, that region seems to be disrupted, could have been disrupted even in this early phase of treatment, and that may be involved in predicting the future heavy drinking days. So we did a whole brain analysis to look at how every part of the brain, every little corner and structural and functional response of the brain codes the response to those pictures. And we call that a voxel-based analysis. And the whole brain then spits out the response to stress, alcohol, and neutral. And just as we did with the physiology that Dr. Blaine talked, we looked at stress versus neutral and alcohol cue versus neutral brain response. And then the neutral alone to look at what is the tone in the neutral state, in the sort of basal control state. And then that spits out data of where there is activation or where there are increases in blood flow and response and where there is a decrease. And that allows us to then map out how the brain is functioning in response to these triggers or cues that individuals face normally in their environment.
Thank you very much for elaborating on the framework of your research. So let's get to what you and your team found. Let's start with study 1, which observed patients' responses to alcohol, stress, or neutral cues. What were your main findings here?
Okay, I'll start. Using this new paradigm with the sustained exposure to visual cues, we replicated our previous findings with a different design that showed that relative to control subjects, patients with AUD showed significant hyperactivity in their ventromedial prefrontal cortex in response to neutral images, but significant hypoactivation in the VMPFC and the ventral striatum in response to stress images and to alcohol cues. These findings suggest that people with AUDs might not be able to recruit brain areas or networks associated with future goal-oriented executive control. So it's more difficult to say no to a drink when one sees one's favorite beer, especially if a person is stressed out. Additionally, the hypoactivity in the ventral striatum might be related to the reality that even though a person's desire and wanting for alcohol is increasing, the liking of it decreases. So it's not as fun or as relieving as it had been in the past.
In addition, what we found in study 2 is that in a larger group of patients, these same regions were shown to be disrupted, the ones that were disrupted in comparison to healthy controls. And the level of disruption was affected by the days of abstinence. The number of days the patients had been abstinent is directly correlated with the level of disruption in that circuitry. This is important because people struggle with recovery and initiating recovery, and it is often in the AA community, it is one day at a time. Take each day towards recovery and take it slow and take it one day at a time. And that's essentially what we were seeing, that each day of abstinence mattered in terms of having just a little bit better functional response in controlling and regulating our responses, our emotions, and our pleasurable responses in these trigger situations. So what it says is that it's very hard to accrue the number of days of abstinence because, in fact, the brain remains disrupted. With each day of abstinence, however, it does start to recover. So the higher the number of days of abstinence you have, the better the person is doing, in the sense that the lower the number of heavy drinking days during this early phase. So they start to do better, they're improving. However, what jeopardizes recovery and jeopardizes early treatment is, in fact, that it's so difficult to put together that one day at a time, because the brain regions that regulate our responses to relapse risk are not functioning well.
And as Dr. Sinha said, an additional few days of abstinence might not seem like much, but each day of sobriety allows the brain to heal, as she says, and it also gives the person time to work on developing new coping mechanisms and get social support during this critical time.
Did any of the results of your study stand out to you or surprise you?
I can start. The thing that was surprising to me was that one sort of truism we have in psychology is that the best predictor of future behavior is past behavior. But we were able to show that even after controlling for past behavior, the most predictive thing are these dysfunctional brain responses to stress and alcohol cues.
Yeah, I would just add that an important takeaway is that a large amount of alcohol intake over the years, months, and days has a very significant effect on the brain and the body. And it is going to take a while to recover. And really, that's what our data are saying, is that one day at a time, each day at a time will impact slow recovery. Now, we do not know how long this is going to take and whether all of these circuits that are disrupted do come back in terms of helping somebody recover and regain their functional control over stressors, over making them stronger, over alcohol-related situations, and learning the new coping mechanisms that we often teach them in treatment. And so I think the key thing here is to understand that there is a hit on the brain circuits that are involved in stress and coping with stress, and involved in regulating our pleasure circuits, both of which then drive the need to consume more alcohol and sort of come back to the level at which the brain has learned to function under the effects of alcohol.
Also, just in terms of supporting common wisdom or wisdom that's been passed down through AA, in addition to one day at a time, our results do support the avoidance of people, places, and things. So alcohol and stress cues in your daily life that remind you of drinking, especially in this early time.
Now, I'm going to ask you to go back and elaborate a little bit more on, what we do know and still what we don't know. But first, I do want to ask if there are any limitations to your study that may have affected what you and your team found.
Sure. One important limitation is that about half of the participants with alcohol use disorders were regular smokers. So we cannot rule out the effects of nicotine on the brain response. Another limitation was just the sample size was very large for an MRI study, but was not large enough for us to look at the effects of biological sex, trauma history, or recent stress, which are all very important for your brain response to alcohol and stress.
Okay, so now I'm going to ask you both to take a little step back and give some perspective. As your article notes, there's been limited research on how each day of abstinence from alcohol affects certain brain areas, and we also do not know a lot about how brain recovery may affect lapses to drinking during early treatment. So how does your work add to the overall body of knowledge about treatment for alcohol use disorder?
Yeah, I can start. I would say that one important implication of these findings is that each day matters. And so we want to keep people abstinent or severely reduced in their drinking so that we allow the brain to recover. But also a key implication is that this is a high-risk period. The early phase is a high-risk period for relapse. The treatment data show us that. But now what we know is that this is a circuitry that is disrupted, the one that we've identified. And if we can identify treatments, medications, or device-based treatments, other kinds of interventions that can alter the functioning of this circuitry, normalize it or rescue it or make it function better, reduce the level of disruption, that would be a rescue mode, helping it to recover back more quickly could also be a strategy. These would be all strategies for intervention. So we've identified the circuit, and we've also identified where the effect is, as well as the fact that in this early phase, it may require some specific different intervention to help folks initiate recovery and maintain it in this very early high-risk period.
Yeah, right. As Dr. Sinha said, one implication, because each day matters, is that investing in intensive outpatient or partial hospitalization programs that provide higher levels of support and counseling may help people get sober and stay sober during that initial time to allow their brain to potentially recover.
And we've touched upon this a bit about how your research supports the approach of treatment programs, but going forward, what would you say some of the implications of your work would have for programs that provide treatment for alcohol use disorder?
Well, I think one additional piece is that there is a lot of development going on at the NIH and among many of us in our labs for developing new medications. And these new medications are being tested in animal models, but also in lab studies, in early phase studies. And we're identifying that these compounds may be more specific to these regions of the brain that are disrupted. And so we might actually think about also, for example, a pharmacological intervention that is more suited for this early phase of treatment, that in fact does slowly help the individual not only get stronger and recover in this functional disruption that we see in the circuitry, but also perhaps engage with treatments that Dr. Blaine was talking about, partial hospital program or intensive outpatient treatment, engage better with them because they're slowly feeling stronger. And so there's a place for pharmacological interventions. Another intervention that is being tested are things like stimulation devices, brain stimulation devices. And because one of the regions we are talking about is a prefrontal region right behind the forehead, a medial prefrontal region, that's an area that is accessible using stimulation devices. And so that's another exciting intervention that could be used in this early phase. We don't know how those devices fully work. However, there's a lot of research going on in that arena.
So in an attempt to wrap up this important work, what are the key points that researchers, clinicians, and other mental health professionals should take away from your work?
I can start by identifying certain key things. The first is the number of days of abstinence matters. It matters a lot. So if I'm a clinician and I'm evaluating somebody, if they had their last drink yesterday and had a number of drinks, today they're motivated, absolutely. You have to go with their strength of motivation. However, we need to know that it's going to be very hard for them to survive through that day and then move it to the next day. Clinicians actually know this from their wonderful clinical experience. They have learned that from their patients. But these are data now taking that a step further and saying that each day matters because the brain is disrupted. And so the second point would be that each day of abstinence is affecting brain disruption. Heavy drinking affects brain disruption, and then on the other side, in initiating recovery, each day of abstinence affects the level of disruption. But then the third point is that accruing the number of days of abstinence matters and helps with recovery. And so giving people support through different interventions can really help them accrue abstinence and get started on their way towards recovery so that they can get stronger and maintain that.
Right. So I would just sum it all up by saying we have shown some neurobiological evidence that taking it one day at a time is challenging, but necessary and worthwhile for people.
And finally, what are some recommendations you have for further research in this area?
Well, as Dr. Blaine mentioned about the limitations, we do need to assess whether this pattern is true for men and women. and those with different types of biologies as a function of their history, whether they have had trauma histories, high levels of adversity, and so on. So that's a really critical piece of it. But I think the other piece is the development of new interventions. We have new interventions that we have been testing that are going to be coming out very soon that have shown that those who are more severe, so individuals who have a hard time putting together those days of abstinence, who may have high levels of craving and high levels of some alcohol withdrawal symptoms, they may need extra help. And in fact, there are interventions that do target those subgroups. It's important to know that alcohol, because it's a sort of coping tool, it varies in terms of how people use it and how severely they use it. So there are a lot of what we call individual differences. And so we need to understand who the subgroups are and that are affected by this functional disruption, and then really target our treatments in a way, what we call in a precision medicine way, to identify those who have more severe symptomatology versus not, and other important markers that show us differential effects of chronic alcohol use.
I would just add that we're also looking forward to using this paradigm in longitudinal studies so that we can watch people's brains recover over time, so that we can measure the responses to pharmacological or psychological interventions.
Dr. Sara Blaine and Dr. Rajita Sinha, co-authors of an article in our November issue evaluating changes in the brain and drinking outcomes during early outpatient treatment for alcohol use disorder. Thank you both for speaking with us.
Thank you for having us.
This concludes this episode of AJP Audio. You can rate and review the podcast on iTunes, Stitcher, or wherever you listen to it. Please also visit our website, ajp.psychiatryonline.org, to check out trending articles, find CME courses, and watch videos highlighting some of our other articles. APA Publishing has other podcasts you can listen to. Psychiatry Unbound is the books podcast from APA Publishing. It's hosted by Dr. Laura Roberts, editor-in-chief of APA Books. Also check out From Pages to Practice, which reviews the latest research published in the journal Psychiatric Services. It's hosted by Dr. Lisa Dixon, editor-in-chief of the journal, along with Dr. Josh Beresin. You can subscribe to these podcasts on Apple, Google, Spotify, or on any of the popular platforms.